Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent. And today we are joined by Professor Yap Boom, the Deputy Incident Manager from the IMST. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you, Director Margaret. Good morning, good afternoon, good evening, depending on where you are. So I will take the brief today on behalf of Dr. Kaseya, our Director General, who unfortunately is unable to take the call, though he was really willing to take it today. But he will be joining us next week with the Ministry of Health of Namibia. So I'm currently taking it from Swakopmund, which is in the region of Erongo, around 400 kilometers west from Windhoek in Namibia. And then we'll come to the reason why we are here today. It's also, as usual, an opportunity to say a big thanks to all our colleagues from the Africa CDC, the IMST, all the different partners, the member states who are currently working tirelessly to really control the different outbreaks that we'll highlight, but also trying to make sure that we have a healthier and safer continent. Over to you, Margaret. So we will go through the health emergency in our continent, coming back from this very intense week that we had last week in Durban for the Conference of Public Health in Africa. Next slide. So this was really a fantastic moment, we have to admit. It was really the time where we had more than 20,000 participants, whether physically or online, from the member state, the different partners, and an important number of scientists and the young scientists really thinking together, engaging together, driving Africa public health transformation all together. So it was really the time where we were intentional on reshaping the global health, where we see Africa really as a co-architect of a fairer, safer, and more self-resilient world. As you all know, with 1.4 billion inhabitants, we are really building a resilient, dignified, and innovative health system for us, by us, to make the world safer, because we are all interconnected. So it was really an opportunity to push and to conclude in Africa collective commitment to self-reliance, innovation, and equity in health, as you will see in the next slide. Next slide. So from all those conversations, we had 8 different tracks. All those scientists, we came out with the Durban Promise. As you well remember, we were emphasizing that it was critical to have this conference despite the short notice, so that we can gather all those brains, African brains, and all the partners to move forward and feed the G20. So this came out with the Durban Promise, where we highlight 4 catalytic priorities, 5 for 5. African manufacturing, innovative health financing, the primary healthcare transformation, the pandemic preparedness and response, and of course, the data ownership and governance, which is an issue of sovereignty. So what really come out to resume that the Durban Promise is that this is Africa time. Really the time to lead, to innovate, and to thrive. And together we will make health the cornerstone of Africa prosperity and global leadership. Next slide. So what do we have really in that promise? We have 7 continental commitments. The first one is to mobilize Africa's wealth and innovation for health sovereignty. You all remember we've been talking about the Abuja Declaration and the investment on domestic funding, financing, and so on. That's one. The second one is really to strengthen the governance and accountability. The third one, to reinvest in public health care and community system. This is where we talk about the primary healthcare transformation or even revolution to really retransform, because that's where everything starts and where everything should end. The fourth commitment is to foster regional solidarity and market efficiency. So there we look at how to strengthen, to accelerate the operationalization of AFMA and APPM, the pool, African pool mechanism, so that we can integrate markets, reduce costs. And once again, Africa is 1.4 billion Africans, so which means there is an important market that needs to be leveraged. The fifth one is to build integrated climate resilience and pandemic ready One Health system. Just to say that the preparedness and of the response that we are having need to be strengthened on the side of the One Health, but also mitigating the impact of the climate change. The sixth one is to reframe health as the strategic investment, not as a charity, but really where we see that the use of $1 can actually have an impact in producing $9. The last one, but not the least, is really to transform this moment into Africa leadership era. And in this era, African institutions that has grown, that have matured, will lead. And the multilateral organization will support and assist on the key area that we will and that we are identifying. Next slide. Now, coming back to our public health events, as you can see, the number of moderate risk, even and high risk keep on increasing. And then when you look at the 180 this year so far and 290 last year, you will see that we are more than 85, around 85% on the number of events. Just to say that while we are ending the closing the month of October, most likely we will have more events this year as compared to last year. So we still have the Mpox, which is the highest in terms of number of member states affected, with 27, but then in terms of number of case, confirmed case, suspected case, confirmed case, but more importantly, number of deaths, definitely cholera with 6,872 is the most challenging disease that the continent is facing. Measles is also present in many countries, including where we are currently in Namibia. We'll come back to that later, affecting 20 countries. Dengue still a big issue for 11 countries. And Lassa fever, though it remains constrained to 4 countries, is an important challenge for our continent. Next slide. Coming to the Ebola virus disease in Bulape, definitely we are in the countdown. 42-day countdown to end the outbreak has started, and on Monday 27th, from the time we discharged the last patient. So we are counting the day. But in the meantime, we highlight the important support, the important work that has been done in the surveillance, but also here in the vaccination. Next slide. In the vaccination, you can see the information where you see 37,178 people have been vaccinated, including 5,000 children between 6 to 11, 5,528 between 12 to 17. This is just to highlight the use of the digitalization of the surveillance. This is the DHS2 tracker that was initially conceived during the Mpox and now which has been used successfully for Ebola. Now, the vaccination of all those people in the zone of Bulape is a significant driver of the successful response that we are seeing currently. As we mentioned, the countdown has started, but it doesn't mean that we are out of the outbreak. If you recall, in 2021 in the North Kivu, I think it was around the 38 days that we had a confirmed case. So we need to be vigilant. We need to strengthen the monitoring and the surveillance, at the same time to engage, keep on engaging the community. And we are highlighting this guide that has been prepared by Africa CDC, WHO, and other partners, so that the community healthcare workers and all the partners are well equipped when they engage the community. So this outbreak is also an opportunity to sustain the preparedness of Ebola. That's also why we are talking about the preventive vaccination against Ebola. Yes, we vaccinated 37,000 people in Bulape, but there are many other provinces in DRC that have current episode of Ebola. So it's the time also to do the preventive vaccination where we can vaccinate the healthcare workers, the frontline workers in some of those regions that are exposed to Ebola. So that's the work that Africa CDC, WHO, and the Ministry of Health are planning. And then we believe that before the end of this year, we'll take advantage of this outbreak to have our healthcare worker being protected with the vaccine. Next slide. The Virivalis fever is a carry-on in Senegal, though it's reducing in Mauritania. In Senegal, we have 26 deaths with a case fatality ratio of 8.6%. You can see that the number of deaths has increased from 2 to 6, while the total people recover is around 246. So currently, 6 people are being hospitalized. So we support also the country with the deployment of the search team. But what is important to highlight is that in Senegal, the surveillance is quite strong and making sure that they can really identify using the One Health approach, not only the transmission amongst the human, but also ensuring that in the animal side, things are happening. As you can see, more than 11,000 animals has been vaccinated. Next slide. The situation of Mpox, we continue to see the decrease in the number of cases, which is really reassuring as we move toward hopefully the end of this outbreak. Remember, the committee, the ECG, will be sitting the 2nd of December, and then we will reassess the evolution of all suspected confirmed cases, but also the death. Now, we keep on seeing the decrease, but we have some new country like Namibia where we are currently supporting. And as you will see, you have other countries where we can see an increase in the number of cases and where urgent action, urgent support is being implemented. Next slide. Now, talking about those countries, you can see that Kenya, Liberia, and Ghana are the country of concern, not only on the percentage of increase, which is quite high for Kenya and Liberia. You can see 66% for Kenya, 39% for Liberia. Ghana is only 7%, but when you see the numbers, the weekly numbers for the last 6 weeks, you can easily see that Kenya, Liberia, and Ghana are the one that were really concerned because of the number on one side, but the fact that we continue to see an increase. We gladly see the slowdown in Uganda, DRC, and Sierra Leone, which is we keep on confirming. So this highlights that we need to be very vigilant because different countries have different stories, different epidemiology, and we need to ensure that the transition roadmap that we work together with the member state is being implemented as we move toward what we expect to be the end of this pandemic. Next slide. Now, this is just to remind ourselves the lesson learned. As we move, we learn. What we've seen is that there are 5 key drivers for Mpox control at the source to really reduce the cost, especially considering the new era where we are. And the first driver is the health minister leadership and oversight. Really, at that political level, the contribution, the engagement is critical. Then we have the multidisciplinary rapid response team, the community-based surveillance that help for the active tracing. That's why most of the time we come back to some of the key indicators, and I will come back to that later when I will be comparing the different countries. But also the prompt isolation and case management, and lastly, the unified outbreak response and database. Next slide. So this was also to introduce the reason why we are in Namibia, because some people can actually wonder why going to Namibia, why they only have 2 cases. But it's actually to implement those drivers. We had the buy-in from the leadership. I mentioned that next week we'll have this briefing will be done with our Director General and the Minister of Health, who's really supporting to ensure that the country has a timely and efficient response to the outbreak. So as per now, we have 2 confirmed cases that we've been able to see. We've been able to see how the country has implemented the surveillance in window where the coordination is happening, but here in Swedkop Mund, where the case has been declared and where they are all admitted. So the testing coverage is 100%, testing rate 100%. The test positivity rate is 14.3%, which means they have an important number of contacts. You can see 53, 53 contacts. This is, for now, most likely the country with the highest number of contacts listed, which is great because then we have a better control of the spread of the disease within the country. So we are also there to support and ensure that they do the right thing at the right time. And hopefully that Namibia can be one of the first countries really to control the outbreak with a very small number of cases. This is the hope, and this is why today we are taking the briefing from Namibia. Next slide. Now, going back to DSC, where we continue to gladly see the reduction of the number of cases, and you can see from 90 to 61 in the new case, but also the reduction on the number of death. We have no zero death for this week. Now, the challenge that we have with DSC currently, you can see the testing coverage is really low, 16%. The testing rate is 35%. So overall, you can see a decrease on the notification, the new case, and the test positivity rate. So this is an alert for all of us who are supporting the country to ensure that we keep on following the challenge, as you all know, dealing at the same time with an Ebola outbreak, dealing with Mpox outbreak, measles and others, and cholera as well, make it really difficult. So it's important to highlight that so that we can provide adequate support to the member state. Next slide. Now, in comparison to DSC, we see in Sierra Leone that the indicator remains very high. The testing coverage 100%, testing rate 100%, the test positivity rate 20%, which means the 5 cases that we've seen this week are really the ones that are the product of a community-based surveillance, household per household, tracking the case in the community. So that gives more confidence on the reduction. You remember the zero case operation was launched sometime in August. So we are glad to see that at least we are with less than 10 cases within a week. And this is really the products of a strong RCC action, including the radio discussion, deployment of youth mobilizer, which can allow the community to be engaged because the disease we've seen is we're quite spreading within the youth, which are also the people using the social media and so on. So those engagements are giving good result, and then we command the Sierra Leone to continue until they get the 0 case per week, as was strengthening by the Minister of Health a few months ago. Next slide. In Liberia, the neighboring country where our colleagues were, is different, completely different. We see the increase in the number of cases that has increased by 63% from 76 last week to 124. We also have an increase in the number of deaths from 0 to 2. And then we have the circulation of the 2A and 2B. So what is happening currently in Liberia, you can also see from the indicator, the testing coverage is good, which means that most of the suspects has been tested. The testing rate is 100%, which means that all the sample arriving to the lab are tested. That is good. Now, what is less good is the test positivity, around 76%. That means that the people that are tested are those who are in late stage of the disease and most likely those who come to the health facility. So the burden on what is happening in the community in Montserrado, which is the hotspot, which account for more than 70%, people are still in the community. So this was one of the outcome of the interaction review. And we believe that with the new leadership that we will support, we will ensure that the active tracing is being implemented so that we can have the same success story that we've seen in the neighboring country of Sierra Leone. The dose of vaccine are there. 20,000 has been deployed. 7,841 has been vaccinated, which means the vaccine should be used efficiently to target the population that really need them because they are vulnerable, people living with HIV, or because they have a high risk of spreading the disease. Next slide. Now, moving from Liberia to Kenya, we also see this week we are seeing a decrease from 51 to 28, though we have been seeing for the last 3 weeks a decrease, which is quite encouraging because we were concerned the fact that Nairobi became the second hotspot in the country, and you know when you have the disease within the capital city, then it can bring some other challenges. So Mombasa, Busia, Nairobi together represent 63% of the total confirmed case. But when you look at the number of contact listed, we have less than 1 per 1, which is quite a challenge. Next slide. In vaccine delivery, so we are slowly but surely moving to the 5 million dose of vaccine delivered to 16 countries. So we have 13 countries that have successfully rolled out the Mpox vaccine. More than 1.54 million persons currently have been vaccinated. So the important news today is that the partnership between Africa CDC and Bavarian Nordic has led to a donation of 110,000 doses of MVABN vaccine that has been received early this week in Uganda. That will definitely be a catalytic for Uganda, which is also moving toward the end of the outbreak in their country. Next slide. So from Uganda to DSC, giving the vaccine is important. Next slide. But it also required to have the infrastructure, but also the cold chain. So we appreciate that this week the World Food Program, together with the different partners, has made that important donation to the Ministry of Health of DSC to ensure that they have the appropriate infrastructure to keep those vaccines that are critical. On the other side, the vaccine with the LC16, which was, remember, a donation by the Japanese government, is still ongoing. To date, 285,000 people have been reached so far, mainly in Sankuru and Kinshasa province. So that is an important development because as we move toward controlling the outbreak, this vaccine will also allow to increase the herd immunity, especially in the area like Sankuru, where Mpox is endemic. Next slide. From Mpox to cholera, remember I highlight that yes, Mpox is touching a bigger number of member states, but cholera with 23 member states high more important number of deaths. As you can see, 6,080 and 54 with a case fatality rate of 2.3% is definitely the biggest challenge as we do speak now. The total case so far are 394 cases that are across the 23 member states. And as you keep on comparing, you can see that we are almost 50,000 cases more than what we had last year in 2024. And we still have 2 months that are coming before the end of this year. And the biggest challenge with those 2 months is also the months where you have the rainy season in quite a number of cholera affected countries, which will be a catalyzer of the Ebola outbreak if we don't implement our activity, our action on time. Next slide. So as you see in this table, we have Angola, we have Burundi that are really leading currently the increase in terms of percentage of change, where we have 700% increase in Angola for the last 6 weeks. We really compare 6 weeks to 6 weeks together. Burundi as well, a significant increase. And you have other countries, Sudan, DRC, South Sudan, though we can see the decrease, you can see that the numbers are much more important as compared to the Angola and Burundi. Next slide. So coming to Burundi specifically, we can see that we have a slight decrease, but the number remain very high, around more than 200 and 284 cases last week. Now, the hotspot are those areas of Bujumbura North, Bujumbura Center, South as well, but those are the part of the country where the access to water is really a big challenge. It's a big challenge also on the side of the access to toilet. You have quite a number of households that are sharing toilet that are too close to the home. Therefore, there is a high possibility of cholera transmission on one side, but also the fact that they don't have water, they will use the water from the river, which is a key driver for the cholera. What is important to highlight is the strong leadership that the country is taking at the highest level with the First Lady of Burundi that has organized early this week that celebration engaging the communities to fight against the disease of dirty hands, which cholera is really on the top. So now what is planned in Burundi is to have that high level meeting where they will mobilize resource and partners as they did for Mpox, that one. They are also working currently and tirelessly to ensure that they have a proper estimate of the dose of vaccine that they will need to stop the cholera in their countries. Next slide. In Angola, once again, this is really the country that is highlighting that the multi-sectorial approach that that is needed is missing. As you can see, the first wave has properly ended, and then you have this second wave, and the number of cases keep on increasing. From last week, where we had 968 cases, we are moving now to 1,043 cases. Why? Because there are new districts that are showing some cases, but also because the coverage of the previous vaccination were not complete. Therefore, you have those new cases that are arriving. And this also push for leadership, ensuring that we have infrastructure that are being supported. As we are seeing in Burundi currently, you have the private sector, the telecom companies that are coming on board to establish some new borehole in some area of Bujumbura where there is no access to water. So similarly, in Angola, like many other cholera-affected countries, it's critical to have those public-private partnership also engaging the Minister out of Health, Infrastructure and Planning so that the access to water, those infrastructure are in place. Providing the vaccine is great to stop, but you can see that it's not enough. It's definitely the infrastructure that are needed. And this is how the IMST will be pushing at the political level to ensure that the Continental Task Force by the President is established at the country level so that the leadership engage all the different partners, the different actors, the key stakeholders to ensure that there is a long life and sustainable solution to address cholera in those countries. Next slide. Now, we've seen that Ebola, we are moving toward the end of this outbreak, though we need to remain vigilant. Vaccine has been playing an important role with 36,000 people that have been vaccinated, and we are also moving toward the preventive vaccination where other provinces and even other countries that could be exposed to cholera can prevent by vaccinating their healthcare workers. The Rift Valley fever is continuing to spread in Senegal, a bit in Mauritania, and then it keep on reminding us the importance of cross-border coordination, but also the One Health approach, as animals are also quite affected, especially the number of abortions that we are seeing in those animals in Senegal. The Mpox, we keep on seeing the decrease, almost 80% from the peak of 2025, which is quite encouraging. Those few countries, Kenya, Liberia, Ghana, that are quite concerning when we see the continuous increase in number of cases that we are seeing. And we have new countries, Namibia, where we currently are, to ensure that they do the right thing for the beginning. And we commend the leadership of the Ministry of Health, who is really ensuring that the case remain controlled, isolated, managed to ensure that they stop the transmission at the source. For cholera, the escalation is continuing in Burundi, though the response, the multi-sectorial approach is being implemented. Angola, we are seeing the second wave that is going up, and then also reminding us as IMST and all the partners that we need to work together as a continental to ensure that we implement the lesson learned from Mpox and the need to have the multi-sectorial approach so that we can build the infrastructure needed to ensure that our population have access to clean water, has access to toilet, so that we can really stop this continental challenge. So I will stop there, and I'll be happy to take the question of our dear journalist.
Thank you, Prof. Let's take the first two questions. We have one here from Mount Joy Chikura, a reporter from Duma FM in Botswana. The question is, as the SADC region braces for rainy season, what interventions are in place to curb or mitigate cases of malaria, death from malaria? That's the first question. The second question is from Jacob Walton, Africa-based reporter for Impact Newswire in China. The question is, kindly explain whether Africa CDC has a regional data protection and sharing policy and how it's transforming cross-border cooperation from disease surveillance to migration management. Hand over the floor back to you, Prof.
Thank you so much for the great question. So Dr. Mercy will handle the second question on the data sharing agreement that Africa CDC is leading, but also the continental database that we are really moving forward. And for the colleagues from Botswana asking what is being done to prevent actually the rainy season. As mentioned, once again, we are here in Namibia, where there has been this outbreak of malaria that led to around 100 cases. So the message is the same: is to support the country on the distribution of the nets to ensure that most of the population in those areas that are affected are protected. The same way that we are supporting countries in West and Central Africa who are used to malaria, actually who are endemic for malaria. So one is the prevention with the use of the net for the household, but two is really to engage the community, because for the malaria to spread, you need to have the environment where the mosquito can make their eggs. So with the support of the community, ensuring that the environment is clean enough, that's also how the SADC country are going to contribute to prevent the upcoming increase on malaria. So this is the support that you are working with them. But now I will let Dr. Mercy handle the question on the data agreement and data protection.
Thank you so much, Prof. And thanks also for that question around the data sharing and data protection policies at Africa CDC. So basically, Africa CDC has developed several policy documents and guidelines to ensure that the data that is coming in from countries as well as partners is well secured. We have developed what we call a health information exchange policy and standard. That's one of the documents that we've developed that has several policies and standards within that framework. And within that, we have clearly outlined the governance standards and as well as the policies that would govern the data that is being shared. In addition, we also have some legal standards or legal clauses within that document, which also speaks to the privacy, speaks to the security, as well as speaks to the vocabulary standards that we definitely are recommending for our countries. And may please you to know that within this document, we also have the data sharing standards that we have clearly outlined, and it has been validated by all the member states. We did a regional validation across all the 5 regions where countries how to send in their technical focal points to look at it, align it to the national standards to ensure that there are no contradicting clauses in those documents. And that document has been validated and launched. So we are currently supporting countries to conduct maturity assessment to see where they are, as well as help them now to be able to attain those standards for information sharing. And at Africa CDC, we are doing the same. We've been able to establish a data center because that's part of the entire framework. We've been able to establish a data center that is also guiding how and supporting the data management processes, as well as the archiving of the data that comes in from our member states. In addition, we have also developed a digital transformation strategy that will span from 2020, that's spanning from 2020 to 2030. And that is also reshaping and redesigning the entire digital health architecture in Africa. And within that framework, we are really championing and ensuring that we support in digitizing healthcare. And of course, that also has some implications in terms of data policy and privacy. So we are really working towards that. And in addition to it, we have also developed our data sharing agreements with member states, as well as a continental data architecture that is also supporting not only the data sharing, but also we are also working with countries to ensure that we add some value to the data that comes into Africa CDC, and more or less provide peer-to-peer mentorship, as well as analysis analytical support to the data that we do receive from countries. So basically, those policies does exist, and as Africa CDC, we are not yet there in terms of hitting all the milestones, but we've made significant progress. Thank you so much, Prof.
Yes, thank you, Mercy. Just to add to the colleagues from Botswana specifically, what Botswana also has been doing is to ensure that the medical countermeasure are being procured with the support of the pool procurement mechanism that Africa CDC is pushing, meaning mainly the drugs, but also in the environment. You may remember I mentioned that the involvement of the community to ensure that the site for malaria for the mosquito are not there. They've done some targeted environment control in area with stagnant water, especially in Botswana, but also in Namibia, just to highlight that specifically for the country where you are coming from.
Thank you, Prof. Let's take the next two questions. We have one here that says, could you give us your assessment of the use of Mubanga in the latest Ebola outbreak in the DRC? Is this the first time that this treatment has been used in the outbreak? And is this something that will be used in the future, potentially reducing the number of deaths? That's the first question. And then the other one talks about the latest situation in coordinating the cholera response in Africa since the launch of the Emergency Preparedness and Response Plan in September 2025 to February 2026, under His Excellency Hichilema, the President of Zambia. So I think the question there is, what is the latest in terms of the coordination aspect of the cholera response? Back to you, Prof.
Thank you. Thank you so much for those two critical questions. And when we say at the end of our briefing that we are accountable through your question, you can see the type of question that we are having, and we are happy to respond. So for the Ebanga or MAP 114 that has been used during the outbreak, so what we've seen, though it was not what we call a clinical trial, because that happened a while ago, confirming the good result of Ebanga. So yes, it has been used in previous outbreak when it was evaluated. But this time around, what we've seen is that in the early phase of this outbreak, when those were not yet available in Bulape, 95% of the patients that were hospitalized, therefore not receive the Ebanga, died, while 35% of those who have received somewhere in the early stage or on the late stage actually passed away. So we have on one side 95%, who passed away, and in the other part, the 35 or people who have has access. So now that's not the most important. It's an critical information, but the most important is the availability of the Ebanga, which is not produced in the continent. It's actually the dose that are available were around 100 doses that were available at the INRB, because that's where the study took place at some point. Now we need to move forward and to ensure that this drug is being locally produced, so that when those other outbreaks will occur, we'll have a significant stock of the dose available in DRC and also in countries that have been seeing some episode of Ebola. Now, going to the question of cholera, the cholera response. So since the plan, what happened? The first thing that happened was to integrate, to integrate the cholera within the mechanism of the IMST, which has been done. We have 23 partners dedicated to cholera that has been included with what we call the different pillars. So they are working together to ensure that we have this fast track incident action plan to respond to cholera. That is one. The second one, during the United Nations General Assembly, there has been an exercise to mobilize some resources, specifically the vaccine. So the Global Alliance for Vaccine Initiative, Gavi, has committed 10 million doses of vaccine that will be made available to countries in need. So during the press, I mentioned the Burundi that is seeing the escalation of the number of cases. So before this briefing, we were engaging the country to see where they stand in terms of the demand for those vaccines. So as soon as it's ready, they will submit the demand, and the vaccine are already available to ensure that they can receive it in the limited time. So we have those that are available. So what also happened last week during the CFIA, we also engaged different partners to mobilize the resources. So those are few actions. Now, the support to country is not waiting all those resources. We have a different team from WHO, for Africa CDC, and other partners that has been in Sudan, in Chad. We have a number of tons of support that has been provided. So we support the countries, but we need to mobilize more resources so that we can accelerate, especially as we see the rainy season that is coming up. Over to you, Director Margaret.
Thank you, Prof. Let's take the next two questions. We have two questions here from Rachel Abuja, the Nigerian News Agency reporter. The question is, given that the Mpox outbreak has reduced by almost 80%, but still poses concern in countries like Kenya, Liberia, and Ghana, what specific strategies is Africa CDC putting in place to prevent resurgence, especially in urban areas where community transmission remains high? And then the second question is about cholera, and that it remains the continent's biggest challenge, with over 6,000 deaths so far this year. How is Africa CDC supporting affected member states like Angola and Burundi to strengthen water, sanitation, and hygiene infrastructure and ensure a more sustainable multi-sectoral response? Back to you, Prof.
Thank you so much, Rachel, for those two very pertinent questions. So you rightly mentioned that we gladly see that 80% reduction in most countries, which means that we've been learning. We've really been learning from our experience. But then you have the country that you've mentioned, Kenya, you've mentioned Liberia, and what we are doing. So let's start with Liberia. We sat together. We also brought some colleagues from Sierra Leone to share the experience during what we call an incident action review, interaction review, sorry, where we went deep dive on understanding the current response. And then we agreed that the key challenges is really to strengthen the community-based surveillance, which unfortunately requires a significant amount of money, because you need community healthcare workers in the ground moving household per household. So currently what we are doing is to ensure that all the recommendations of that EAR are being implemented. On one side, that we are also supporting the country to mobilize the resources. There is a change of leadership at the NPHI in Liberia, and we are supporting them so that quickly those actions on the surveillance can be implemented. We also have the vaccination. Kenya, that we've mentioned. Kenya has received 10,000 doses of vaccine that they've used. So now we are working with them so that they can receive 20,000 extra dose of vaccine. So that will go hand in hand with the community communication and risk and engagement to ensure that the population, the target population, people living with HIV, but also the one that are the most at risk of spreading the disease, are well targeted. When the 20,000 doses of vaccine arrive, they will be the beneficiaries. So we have, I mentioned the surveillance, I mentioned the vaccination and the communication. So this is continuing because we are not going to rest until all the member states are reaching a level, a threshold that is acceptable to allow them to move into transitioning the Mpox in the national surveillance. So the strategy basically to summarize is really to focus on those hotspots to ensure that the surveillance, the vaccination, whatever is needed, the communication, and of course the laboratory is being well implemented. So for cholera, what is being done to ensure that there is a sustainable response? And you rightly so, Angola is showing us that if the infrastructure are not being changed, then it will come over and over. So in Burundi, as I mentioned, the engagement at the highest level, at the political level, the president and now the first lady, to engage in this public-private partnership, this telecommunication brand, which will now implement 14 borehole to ensure that the population has access to clean water. Those are the actions that we support, that we encourage. And in Angola also, we'll be supporting to ensure that the ministry or the partners who are not specifically involved in the health place, but meaning investing on those borehole and access to water are engaged. So this is our role because remember, Africa CDC, we work at the operational, strategic, and political level. So we need to reach all those three to ensure that cholera is really being addressed the way it should be in all those countries.
Thank you, Prof. Let's take the next two questions. We have one from Yusuf Suma, is a health journalist from Freetown in Sierra Leone. The question is, the Mpox fight in Africa had gotten most countries in the continent to forget about other infectious diseases. What is Africa CDC doing to engage leaders in Africa to control cross-border infectious diseases? That's the first question. And then we have another one from Lucia Blanco from the Spain International News Agency. Are you worried about the current health situation in El Fasher and what needs to happen after the city has been taken over by RSF in the midst of reports of atrocities? That's the second question. Back to you.
I didn't get well the second question.
So this is a question, I believe, on Sudan. I understand. So what is the current health? Are we worried about the current health situation and what needs to happen in this case? Back to you, Prof.
Okay, thank you. Thank you so much for the two questions from Yusuf from Sierra Leone and Lucilla about the Sudan. So yes, we've been investing on Mpox and cholera, and it has also been the opportunity to reinforce the challenge of cross-border coordination and collaboration. So what is happening, that we've started early this year of 2025, is to bring together different countries on moving towards signing a memorandum of understanding so that there is an agreement on how the surveillance can move from one country to the other, which also link to the issue of data agreement that Dr. Messi well highlighted previously. So this is a work in progress, and there will be an important meeting in Lusaka by the end of this month, where Africa CDC will be represented, on seeing what are the progress on the cross-border coordination and collaboration. How far are we with this MOU? How far are we with the data management? Because unless we have the ability to move data and to move people from one country to the other. We won't be able to follow the disease because we all know and agree that disease has no borders. Now, for the situation in Sudan, so we have a team of Africa CDC that went there with the peace and security of the African Union just to emphasize, just to actually assess how the situation is ongoing. So you've seen in the different numbers that though there is a decrease, a significant decrease in number of cases and in the number of deaths, we can still see that the number remain quite significant. So the colleagues are in the ground making those support, those assessments, while we are also mobilizing other partners to support in terms of procurement to some of those medical countermeasures that are still needed there. So when you ask the question, it's an important opportunity to remind all ourselves that if we don't have the peace, it makes health more difficult because the access is difficult, the access to the country, access to the patient themselves, and then implement the different solutions that are needed. But our colleagues are committed, and then we believe that with that commitment at the political level, strategic level, operational level, we'll also ensure that Sudan is not left behind, and we can see the decrease, the continued decrease that has started a few weeks ago.
Thank you,
Dr.
Prof.
Messi, Margaret, Dr. Messi wanted to complement.
Thank you, Prof. So yes, this issue in Sudan is really concerning, both looking at it from peace and security angle, but again, looking at it from a health security perspective. We've seen that there are attacks in hospitals. We've seen that there's been adoption of healthcare workers and the killings of patients and all that. In addition to the ongoing outbreaks that's currently plaguing the country. So this really looks and really emphasizes the need for a multi-sectorial approach in the way we handle some of the emergencies. And in this case, there's a lot at stake. There's a lot at stake. We must agree to it. There's a lot at stake looking at, we don't want to say about terrorism, but we just have to look at it from all the different angles. And as Africa CDC, we have our peace and security arm who are on the forefront of this and are really making measures to ensure that they can rapidly assess the situation. And for those interventions that need Africa CDC's quick response, that would be our action in the coming days. But the peace and security are on the forefront of this because this is really a security issue that needs to be looked into.
Great, thank you, Dr. Mercy. Let's take the next two questions. We have one here from Mount Joy, a journalist from the Botswana Duma FM. The question is, Botswana just came out of a state of emergency due to shortage of medicines and other consumables, but the country is facing shortages of ARVs and condoms. What has Africa CDC done to assist with procurement and distribution? And then the second question talks about the Rift Valley fever. The question is, you mentioned that the Rift Valley fever epi situation in Senegal, you mentioned that, so can you expand on RVF epi situation in Mauritania? Thank you. Those are the two questions. Over to you, Prof.
Thank you so much for the question. So I will start with the first one, and on the Rift Valley fever, then Dr. Messi will come to the Rift Valley, the situation. So the Botswana, Namibia, and other countries has been and many other countries actually has been facing the challenge of access to shortage of medical countermeasure. And as you rightly say, there's still the shortage of condom and others. So this crisis, as we think are opportunities. The opportunity here is to remind the world that Africa CDC is pushing on the Africa pool procurement mechanism. So where instead of having one country like Botswana going in the market to access ARVs or to access any other medical countermeasure, we are pushing to have African, all the member states toward using the very same mechanism, because you imagine that the leverage that we will have in buying all those community will not be the same. So this is the support that Africa CDC is bringing to the country, Botswana, Namibia, and many others, to ensure that through the mechanism we've already listed. I think Namibia or Botswana was had a list of around 800 medical countermeasures that was critically needed, and then we were able to identify, if not more than 80% of those. So using that mechanism. So this is an opportunity to highlight that the mechanism is there, and then we need to strengthen, because then as a continent, we'll have more power in negotiating not only the price, but the access. You remember that sometimes during COVID, the vaccine, where we had the possibility to acquire some of them, where we were not giving the opportunity because they were prioritized. So it's a good tool in terms of equity to ensure that we have an equitable access to the medical countermeasure, but also an opportunity to improve the efficiency at a continental level. So this is what Africa CDC is pushing. So I will let Dr. Mercy on the side of the Rift Valley fever.
Dr. Masi, are you there?
Trying to unmute. Yes, so
Yes.
regarding Mauritania has been reporting cases of Rift Valley fever over the past months. And so far, they've reported several cases, both in the animal population as well as in the human population. And as we know, they had a very huge measure. The last major outbreak in Mauritania occurred in 2022. But this year, between September and October, that's first week or second week of October, the last report that we received from them, they've reported at least 17 confirmed human cases. And this also includes, I think, eight deaths thereabout, and with a very high case fatality of over 7%. And these cases have been reported in 5 regions so far. And one of the regions borders Mali. That also shows the risk of cross-border spread, potential cross-border spread, and Burkina Faso as well. Borders Mali. And then there's another region that also borders Senegal, just to tell us that there could be potential spread of cross-border. And given that we're also seeing a lot of pastoral movements or animals, moving across the borders, there could also be likelihood of cross-border spread within the animal population as well. So both countries are still, that Senegal and Mauritania that do border each other, are currently still experiencing active outbreak. In terms of some of the measures that have been put in place, Africa CDC has deployed a response team that are currently on the ground, and they have been supporting the country using a One Health approach in several different activities, strengthening surveillance, and also strengthening the One Health multi-sectorial coordination mechanism in country. Because without the One Health structure in place, definitely it's very difficult to contain the outbreak. That's it from my side. Back to you. But the risk remains high in country. At continental level, we also have assessed the risk, and there's also substantial risk of, say, moderate to high depending on the location, the region we're dealing with. But at continental level, it's moderate. But in the region, that's the West Africa region, where we have those surrounding countries, I think the risk still remains high. Over.
Thank you, Dr. Massey.
Yes. Maybe just to mention that one of the reasons why we've not put Mauritania, why we were doing it last week, is because this week we had no confirmed case, no death. So sometimes we have to choose also to maintain the time. But thanks, Mercy, for really emphasizing the situation in the country. Over to you, Director Margaret.
Thank you. Let's take the last question and cross over to the floor. We have Agnes from New Vision in Uganda. Agnes, you have the floor. Agnes, can you hear us? Agnes, can you hear us?
Yes, I can hear you. You're loud and clear, Margaret.
Go ahead.
Yes, thank you so much for the briefing. Yeah, my question goes to Prof. Boom. Looking at the work that has been done in regard to vaccination, for especially Ebola and Mpox, and the vaccination comes concurrently. It comes at the same time, especially in looking at DRC, where we have Ebola and Mpox patients. So what is Africa CDC doing to enable people embrace vaccination to avoid wastage of resources, considering the issue of vaccine hesitancy? Then I would want to know, so have you particularly encountered challenges in regard to vaccination, and what are you doing? I submit.
Thank you, Agnes. Back to you, Prof.
Yes, thank you. Thank you for this very pertinent question. As you mentioned, we want to avoid any waste, knowing that one dose of Mpox vaccine is around $100. So what is clear is what we call the waste rate for Mpox vaccine is almost zero for all the 1.5 million doses of vaccine that has been used, the MVABN. It has been very significant. So some few doses unfortunately were not used because of the way they were shipped. So on that side, we are safe. The vaccine is very well transported, administered, and so on. Now, in terms of vaccine hesitancy, that's something that we have not seen in most of the countries. If we look at the vaccine absorption, once the funds are available, when the vaccine, the team are in the ground, they are very well accepted. For Ebola, you've seen more than 36,000 people have been vaccinated within a very, very limited time. And this is because of the important community engagement. I just highlight the guide of communicator that we have been using for Ebola. This engagement has been critical to ensure that there is no vaccine hesitancy. Now, just a small hiccup on the side of the Mpox. We have those two different vaccines. We have the MVABN, where I highlighted almost 99% of use with no wasted rate. And we have the LC16, where on that side we have a 30% waste rate. Why? Because when you open one dose, you must vaccinate 250 people, which is not always possible. So that is the challenge, which also, of course, required an important communication. But once again, the hesitancy has not been observed. The waste rate is really low, especially when you have one dose for one person. Either we are talking about Ebola or Mpox, with the caveat of the LC16 that need an important number of people for the vaccination to occur.
Thank you, Prof. And with that, we have come to the end of the briefing this week. I'll hand over the floor back to you for your closing remarks.
Thank you once again. And when we say thank you, when we talk about transparency and accountability, we really appreciate all the questions that you've been asking to us. It allows us to ensure that we remain committed. You ask, we say that we did this, what happened since the plan, and so on. So that's important for us That's why we ensure that we are there every Thursday at the same time. And then we will have next week our Director General together with the Minister, the Honorable Minister of Health and Welfare of Namibia, also to give you where we stand in the continent. So thank you so much to you, all the journalists and all the participants to our press briefing, and of course to all our colleagues who are in the field fighting all those outbreaks and ensuring that we are a healthier and safer continent. Thank you.